Hello and good evening. I think we can get started. Thank you for joining us for the third of 5 sessions of Leukemia Research Foundation's New and Emerging Treatments Conference. The topic tonight is childhood ALL. My name is Carrie Callis, and I'm the Director of Programs at the Leukemia Research Foundation. I'd like to take a moment to thank our supporters of this conference, AbbVie, Bristol Myers Squibb, Daiichi Sankyo, Janssen, Kite, and Novartis. We also want to thank our webinar partners, No ALL and the National Children's Cancer Society. The Leukemia Research Foundation's mission is to cure leukemia by funding innovative research and to support patients and families. The foundation has raised over $83 million in support of its mission and has funded research grants to over 600 new investigators worldwide. Our free support programs for leukemia patients and their loved ones include information and resources, education programs, peer support services, financial assistance, and a directory of other helpful organizations and resources. Just a few quick housekeeping items for the program this evening. All participants will be muted throughout the program. If you already submitted a question at registration, please know that we have your questions. We will do our best to cover as many as possible. You can also type a question into the Q&A box at the bottom of your screen at any time. After today's program, you will be sent a brief evaluation through email. Please take just a moment to complete our evaluation so that we can improve our future programs. Also, this program will be recorded and sent to all participants afterwards. We're grateful to have 2 hematology-oncology experts joining us this evening. Dr. McNear from University of Chicago Medicine will be presenting on childhood ALL, followed by a live Q&A facilitated by Dr. Justin Klein, also from the University of Chicago. He is the chair of our medical advisory board as well. Dr. McNear, I will turn it over to you.
Good evening, everybody. Thank you, Carrie, for that introduction, and thank you to the Leukemia Research Foundation and Dr. Klein for inviting me to participate in this series. As Carrie said, I am a pediatric hematologist and oncologist at the University of Chicago and have a particular interest and expertise in pediatric ALL. And so this evening, I will just take you through some of the recent advancements that have been made in treatment of pediatric ALL, and also where we're moving to with our future therapies. I just have a few disclosures here to show in terms of participation on an advisory board and some discussion of off-label use in the context of ongoing clinical trials. And as you can see, our objectives here are to understand the risk grouping for pediatric acute lymphoblastic leukemia, to review the different phases of treatment for pediatric ALL, to discuss the results of recent trials and how they have shaped our current treatment approaches, and then finally to describe targeted therapies and their incorporation into current and upcoming clinical trials for pediatric ALL. This set of curves here shows the improvement in survival outcomes that we've seen for children who are diagnosed with pediatric ALL over the course of several decades. And as you can see here in the right around 1970, their survival outcomes were unfortunately quite poor, and they have increased really remarkably over recent decades. And a lot of this is due to clinical trials that are conducted amongst cooperative groups, a better understanding of disease biology, and refinement of treatment over the years in order to best tailor therapy to individual patients. I wanted to start with going over initial risk grouping. So that way we have some definitions that we're going to work with tonight. So of course we have acute lymphoblastic leukemia, or ALL. And there are 2 main subtypes of ALL. There's B-ALL and there's T-ALL. When we're talking about children who have B-ALL, we, right at the time of diagnosis, can think about 2 clinical characteristics. One is the age of the child at the time of diagnosis, and also the white blood cell count at the time of diagnosis. And as you can see here, for children who are under the age of 10 and really between the ages of 1 and 10, and who have a white count less than 50 at the time of diagnosis, those children are considered to have NCI standard risk ALL or SR ALL. You'll see on the slides and hear me talk about tonight. And then children who are at least 10 years of age or whose white count is at least 50 at the time of diagnosis have what we consider NCI or National Cancer Institute high risk ALL or HR ALL. Patients with T-ALL automatically are considered to have high-risk ALL just based on this subtype. And then within these other groups, there are some adverse features that change our risk grouping. So children who have standard risk ALL, based on the biology of their disease, the cytogenetics or the chromosomes that are in the leukemia cells, or the way that the disease responds to our chemotherapy. If the response is slow in terms of getting children into remission, then we consider that to be standard risk high or SR high. And for children who have high risk ALL that again has a slow response to our initial treatments, those children may ultimately be considered to have very high risk or VHR ALL. And this just helps us to tailor therapy after our first couple of phases of treatment, again, so that way we can make sure that for that particular child, they're really getting what is considered to be the best care at that time. So when we look at our current projected outcomes, there are certain groups of patients, our SR favorable. So these are children who have favorable chromosomes, favorable biology, and very nice responses to chemotherapy, and even our high risk favorable patients, again, based on disease biology and the quickness of their response, their outcomes are quite good. But as you can see here, for other children who are in the standard risk group or children in the high risk group, and certainly children in the very high risk group, these survival outcomes, event-free survival, EFS, which means that there is a good response to treatment, there's no relapse, there are no problems like that. These outcomes really are okay, but they're not as good as we would like them to be. And certainly for the very high risk children, these outcomes are not nearly where we would like them to be. So unfortunately, regardless of what the initial risk grouping is, if a child has a relapse of their ALL, the outcomes are really quite poor, less than 40% survival. And it's children who initially are diagnosed with what we can tell is standard risk disease. Those children really comprise about half of our relapses. And so this really tells us that there's still progress to be made in terms of improving the outcomes for all of these children. And when we're talking about a breakdown of about how many or what proportion of children fall into each of these risk groups, you can see that our standard risk patients, which are the dark blue and the green pieces of the pie here, this is about 2/3 of the children that we treat. And then our high risk patients make up a little over a quarter of our patients. And then the very high risk patients are a very small group, but obviously given their poor outcomes, we really want to improve how they do. And then we'll get to this precision medicine group a little bit later. This is a small proportion of patients who really already are benefiting from, or we believe will benefit from, some very targeted therapy incorporated into their treatments. As far as the outline of ALL therapy, we talk about therapy in certain phases. We name the various phases of therapy. We start with induction, then consolidation, a phase called interim maintenance number 1, delayed intensification, which is really a reinduction and reconsolidation. Certain protocols include a second interim maintenance phase, and this is all prior to maintenance therapy, which, as you can see here, is quite long, depending on the protocol that we're following. Maintenance therapy is certainly the longest phase of therapy, but it is generally the lightest phase of therapy. It's mostly oral chemotherapy and clinic visits only about once every 4 weeks. And so while the therapy in these initial phases is quite intense and patients are in clinic a lot, once they get to maintenance therapy, then things can really become a bit more close to normal. So I first thought I would talk about some of the recent trials for standard risk or SRB-ALL, and these are Children's Oncology Group trials. The Children's Oncology Group is an international network of hospitals that conduct a large amount of the research that's done in terms of all types of childhood cancers. It's a very large cooperative group. This is a trial that was approved back in 2003, and this really looked for children with standard risk disease if we intensified certain phases of their therapy, the consolidation therapy, the first intermaintenance phase, the delayed intensification. Could we improve the outcomes for those children? And what we learned is that for our standard risk patients, so our standard risk average patients, our standard risk favorable, intensifying those phases of therapy did not improve things at all. For the standard risk high patients, so those were the patients, again, who had an aspect of their biology that was unfavorable or whose disease was slow to respond to treatment, those patients really did benefit from intensification of these cycles of therapy that followed induction. And so this has really now become our standard for children who, after induction, are identified as having the standard risk high subtype of ALL. We actually switch them to a backbone of chemotherapy that looks much more like high risk therapy. And this has improved the outcomes in those groups of patients. The subsequent Children's Oncology Group trial, which was approved in 2009, looked at a few questions related to the maintenance therapy. In maintenance therapy, there's a lot of oral chemotherapy, one of which is weekly oral methotrexate. And this study asked the question of whether we intensified that oral methotrexate in maintenance therapy, if that would improve outcomes for these patients. But then it also looked at decreasing the frequency of the pulses of certain types of chemotherapy, vincristine and dexamethasone being a steroid. And these pulses really can carry a lot of side effects. And so there was certainly interest in looking at whether they were really necessary to do every 4 weeks or if the frequency of them could be decreased. And what this trial found was that intensifying the oral methotrexate didn't help in terms of improving outcomes, but also importantly that we could decrease the frequency of the vincristine and steroid pulses and not have a decrement in our outcomes. And so we've really been able to scale back the intensity of that maintenance therapy as far as these pulses go. And that's important for these children. Vincristine and steroids can cause bone pain and nerve pain. Steroids cause moodiness and increased appetite, and kids really don't feel like themselves when they're on steroids. And so to be able to lessen the side effect profile of our therapy is really helpful for these kids as they're going through this. So this is what we looked at for standard risk ALL most recently, and really what's shaped the way our protocols look today. And then similarly, there have been several trials looking at high-risk B-ALL therapy. And so this was, again, a study run by the Children's Oncology Group in the early 2000s. And this study looked at giving 2 different types of steroids during induction and whether there was an improvement in rates of achieving remission in children with high-risk ALL, but also looking at toxicity in terms of bone toxicity, infection risk, all of which are associated with steroids. And this also looked at giving the methotrexate that we use in interim maintenance in 2 different ways. So methotrexate given IV can be given inpatient in a high dose form, accompanied by very aggressive hydration and a medicine that rescues the patients from the side effects of that methotrexate. Or it can be given in doses that start low and then escalate over time and are given in conjunction with the second medication called asparaginase during interim maintenance 1. And what this study found was that the question in induction of the dexamethasone versus the prednisone, the dexamethasone is the more effective anti-leukemic steroid. But what we found was that in children who were 10 years of age and older, it was just too toxic down the road, and in particular in terms of bone health for those children. However, for the younger children, they tolerated the dexamethasone just fine. And so what patients and families will find at this time is the steroid that we use in induction can vary based on a child's risk group and based on a child's age. So some children we will treat with dexamethasone and some children we will treat with prednisone depending on their age. As far as the second question, which was the interim maintenance question, what we found was that using the high dose methotrexate was superior to this lower dose and escalating methotrexate in this first interim maintenance phase. So again, for these high risk patients, instead of giving the low dose that escalates, which is what we give in our standard risk patients, the high dose methotrexate is improved. So, or the high dose methotrexate improves survival. So again, we're tailoring our treatment based on features of the child themselves, their age, as well as the leukemia that they have. And then the subsequent trial to that was approved in 2011. And this was a trial that took these high-risk patients and broke them down even a bit further into a very high-risk group and a high-risk group. The very high-risk group was comprised of patients who were 13 years of age, had adverse biology, slow response to the initial phases of therapy. And we looked at intensifying the treatment in the consolidation and the delayed intensification phases of therapy. And that intensification included adding several different chemotherapy drugs, so including one called cyclophosphamide along with etoposide, and then another arm of this study received cyclophosphamide, etoposide, and clofarabine. And for the high-risk patients, so these are the patients who are at least 10, but under the age of 13, or those who are even younger than 10, but had high white counts at diagnosis, what we looked at was two different ways to give the intrathecal chemotherapy, or the chemotherapy that goes into the spinal fluid. And conventionally, we've always just given intrathecal methotrexate when we do spinal taps. But this study looked at if we gave 3 drugs in those spinal taps instead, would that improve the outcomes, especially in terms of relapses in the central nervous system? And really what this study found was that all of these additions to the therapy, all of these intensifications were either too toxic and led to too many infections, or just were not beneficial. They did not improve the outcomes for patients who received that therapy. And even if overtly they weren't too toxic, without the benefit of them, there was really no reason to incorporate them into these regimens. And then finally, for T-cell ALL and also lymphoblastic lymphoma, which is a very similar cancer to leukemia, except it's mostly in the lymph nodes instead of in the bone marrow as much. The recent studies have again looked at different ways of administering chemotherapy in several of these cycles. Excuse me. So in this trial, again, there was a question of how should we give the IV methotrexate during the interim maintenance 1 phase. And then also here we start to get into some targeted therapy. Nelarabine is a conventional chemotherapy drug, but it seems to preferentially be toxic to the T lymphoblasts as opposed to the B lymphoblasts. And so this is a chemotherapy drug that we knew was effective in relapsed T-cell leukemia, and we wanted to bring to upfront therapy to see if we could improve outcomes for children who have T-cell ALL with the incorporation of this more targeted therapy. And what we found here was interesting in that the way that we give the IV methotrexate in interim maintenance 1 should be different for patients who have T-cell ALL as opposed to B-cell ALL. So in this study, that low dose escalating methotrexate with the addition of asparaginase led to better outcomes for patients as opposed to the high dose methotrexate. And I think many people thought perhaps the high dose methotrexate would be better, but this shows why it's important to do these studies, because we actually found that for patients with T-cell ALL, the Capezi methotrexate, which is the name of that method of giving methotrexate along with asparaginase, was more beneficial. And then really remarkably, what was really remarkable about this trial was the improvement that was provided by the incorporation of nelarabine for patients who had lymphoblastic leukemia. It really decreased the number of relapses in the central nervous system, which really improved the outcomes for these patients overall, and was a very rewarding result to see. Interestingly, though, for patients who had lymphoblastic lymphoma, and again, that is less involvement of the bone marrow, more involvement of the lymph nodes, the benefit of the nelarabine was not so clear in those patients. So again, a demonstration that we really need to think about patients in subgroups and categories and make sure that we're tailoring the treatment appropriately. And then most recently for T-cell ALL, There was a study that incorporated a drug called bortezomib during 2 phases of treatment, induction and delayed intensification. Again, this was a drug that had been shown to be beneficial for patients who had relapses of T-cell ALL. And so we wanted to bring this to frontline therapy in order to see if we could reduce the number of relapses outright. This study ended up having to stop early once the results of this study became known. As I mentioned before, the addition of nelarabine to therapy really improved the outcomes for patients who had T-cell ALL. And in order to be able to incorporate nelarabine into the chemotherapy regimen for all patients, ultimately it was decided to close this trial down because there was not a good way to incorporate it. And I think that just demonstrates the ongoing surveillance of these trials as new results come out. It may impact what we're doing with our new studies and make us say we need to pause this, we need to stop this trial because we've actually found something that's more beneficial to patients that we want to make sure that they get. What we were able to identify, though, is that bortezomib did not seem to be beneficial to patients with T-cell lymphoblastic leukemia, but it did seem to improve the outcomes for those with T-cell lymphoblastic lymphoma. And so that was the opposite of what we saw in nelarabine in the earlier trial. So again, showing that for subgroups of patients, different drugs may provide more benefit to some groups than others. So the take home from a number of these studies, especially the B-cell ALL trials, is that we appear to be at the limit of what we can do in terms of improving outcomes with our conventional chemotherapy drugs. As I said earlier, for our high-risk therapy, which is already quite intense, when we tried to intensify it further, we really didn't see any improvements as far as how patients were doing. And so perhaps it's time to shift our focus. And this is where the future of this comes in. And this is where we start to talk about targeted therapy. So targeted therapies are therapies that are not as broad in their effects as our conventional chemotherapy. They are much more impactful to the cancer cells. In this case, we're talking about leukemia cells, lymphoma cells. There are immunotherapies. These are antibody-based therapies. So an antibody that recognizes a protein or target that's expressed on the surface of these cancer cells. And immunotherapies can work in a number of different ways. Sometimes they can stimulate the patient's own immune system to get rid of that cancer cell then once the antibody is attached to it. Sometimes it brings parts of the immune system together, and sometimes that antibody carries chemotherapy right up to the leukemia cells. There are also small molecules. So these are targeted therapies that basically insert themselves into these signaling pathways that cancer cells have, these pathways that tell cells to continue to divide unchecked. And these targeted therapies can interrupt that process and cause the cells not to proliferate in that way any further. And if we're talking about B-cell ALL, we actually have a number of immunotherapy options that have been shown to be effective in the relapse setting and that we're now working on bringing to upfront therapy. On B-ALL lymphoblasts or the blast cells, there are a couple of targets or proteins that are on the surface of the cells. The most promising targets are one called CD19, you can see here, and one called CD22. As far as targets, as far as therapies targeted against CD19 go, there is one called blinatumomab, which is shown here in this picture. Blinatumomab is composed of 2 antibodies, one that recognizes CD19 and one that recognizes a different protein called CD3. These 2 are cross-linked to one another. And CD3 is expressed on T cells in the body, which are an important part of the immune system. And so what blinatumomab does is it brings these killer T cells or the effector T cells right up next to the leukemia blast cell in order to lead to the destruction of the leukemia blast cell. So this is one mechanism for immunotherapy. Another therapy that targets CD19 is one called tisagenlecleucel, or CAR T therapy is the much easier way to say this. What CAR T therapy is it's composed of T cells that are collected from the patient, and then they are manufactured or engineered to express an antibody on them. And in this case, the antibody is against CD19. And so again, you bring these T cells, which are the killer cells, right up next to the leukemia blast cell in order to enact cell killing. And then finally, as I said, the other promising target here is CD22, and the immunotherapy that is farthest along in development for CD22 is one called inotuzumab. And inotuzumab is an antibody against CD22 that is attached to a chemotherapy drug called calicheamicin. And so here what you have is the immunotherapy or the antibody bringing the chemotherapy drug right up to the leukemia blast cells. So several different mechanisms here, all of which have been shown to be promising in the relapse setting. And not that they don't come with toxicities, they do, but perhaps not as problematic as some of our conventional chemotherapies, depending on the situation. And so we want to look at if we can bring these to the upfront setting, can we reach more cures outright? And so not to go into too much detail here, but this is just a demonstration of the current studies that the Children's Oncology Group is running for B-cell ALL. So we have a trial for children who have standard risk ALL. So again, these are younger children who have relatively low white blood cell counts at the time of diagnosis. In these patients, this is a trial looking at whether or not the addition of blinatumomab will improve outcomes for patients. This trial is our trial for patients who have high-risk B-ALL. So these either are patients who are at least 10 years of age or older, or they have a white count that's at least 50 at the time of diagnosis. This study is looking at whether or not the addition of inotuzumab will improve outcomes for these children. And then finally, we have our very high-risk ALL patients, which are now defined by disease response. And for those patients, they are eligible for CAR T therapy as part of their upfront therapy, because we really know that if there's a very slow disease response and leukemia that's still present at the end of consolidation, our conventional chemotherapy backbone is not going to cure enough of these children. And so we really need to think about them differently. They either will undergo bone marrow transplant, or we're looking at being able to do CAR T therapy at this point in time to see if we can achieve similar outcomes without the process of the transplant. And then finally, we have T-cell ALL. Again, we are looking at an immunotherapy in an upcoming trial, most likely one called daratumumab. This is an antibody, again, against a protein on the surface of the T leukemia cells. It's CD38 is the target. Daratumumab is an antibody that's not attached to anything else. What it relies upon is the person's own immune system, recognizing that this is something that has an antibody on it, and therefore it needs to destroy that cell. And as you can see here, the next T-cell studies are going to split patients into a leukemia group or a lymphoma group, as I described earlier. And the backbone of chemotherapy for the group of patients who have leukemia will include the nelarabine. For the patients who have lymphoma, it will include bortezomib in order to capitalize or use what we've learned in the most recent trials is best for these patients, and then looking at whether or not daratumumab would be effective. And then finally, I just wanted to touch on some of the smaller subgroups because I think it's important to recognize that the biology of these diseases really can also impact what we do from a therapy standpoint. So there's a subtype of ALL called Philadelphia chromosome positive ALL. And in patients who have this subtype of ALL, there's a translocation or a breaking apart of pieces of chromosome 9 and chromosome 22, and they attach together and they bring two genes together called BCR and ABL. And this leads to production of a fusion protein, a BCR, it's called a BCR ABL tyrosine kinase. And this is a protein that in these signaling pathways just tells the cell to divide and divide and divide. What we have for these patients, though, are targeted therapies with inhibitors of these tyrosine kinases. So these are these small molecule inhibitors. And the first one that we've used in this population was called imatinib. And as you can see here, this is this fusion protein that I just described, the BCR-ABL tyrosine kinase. And it is receiving signals from within the cell to just tell the cell to divide and divide and divide. But this is the imatinib here, which sits in this same pocket and blocks that process from happening. And so the cells stop dividing, and ultimately they involute and they die. And so these are some targeted therapies that work differently than immunotherapies. These are small molecules that can insert themselves and disrupt these signaling pathways. So what we have learned with Philadelphia chromosome positive ALL, though, is that this targeted therapy is not enough in and of itself. There's a different type of leukemia called chronic myeloid leukemia, or CML, and that leukemia can be controlled just with the use of imatinib, but we found in ALL that was not adequate. And so what studies have done for this subtype of ALL is include imatinib with a chemotherapy backbone. The first trial to really look at this gave imatinib in increasing durations in 5 different cohorts of patients. And what they were able to demonstrate on this study is that this group of patients, the cohort 5 that received the imatinib continuously, they did as well from a survival outcome standpoint as patients who are undergoing bone marrow transplant, because prior to this, anybody who had Philadelphia chromosome positive ALL, the only way to cure them was with bone marrow transplant, which is a lot to go through. So this was very nice to see that chemotherapy along with this tyrosine kinase inhibitor, the imatinib, could lead to the same survival rates as we were seeing with bone marrow transplant. And then this leads me to a more recently identified subgroup of patients. And what we're looking at here, this is called a heat map. And this is looking at the expression of genes in cells, and then the various rows, each patient is their own row, and using computer algorithms, you can group patients into these different cohorts based on their biology. The cohorts tend to cluster together. So this group up here, you can see with the maroon bar, is TALL. This group here with the teal blue is a particular biology called MLL rearranged, and so on. And what investigators published in 2009 was this group down here, which all clustered together. And there were certain patients in here who had the Philadelphia chromosome, but then there were other patients who clustered down here who did not have a Philadelphia chromosome and did not make that BCR-ABL protein. And so this group of patients was named Philadelphia-like, or BCR-ABL-like ALL. And what was demonstrated also was that these patients with conventional chemotherapy did not fare as well as our patients who did not fall into that gene signature. So these are our other BALL patients who we can see from this cohort, their survival rates were right around 80% or so. But this Philadelphia-like cohort was down around 60%, which was not that far off from the Philadelphia chromosome positive patients prior to adding in the imatinib, when their survival rates were in the 30 to 40% range. And so this really identified this group of patients as a group that could be identified that was not faring so well. And we really needed to try and understand the biology and do better. And I'm not going to get into a whole lot of details of the work that went into it, but what they were able to identify was that these patients with PH-like ALL, there were similar signaling pathways, these tyrosine kinase pathways that were activated in these group of patients. And so, of course, that led to the theory that perhaps these small molecule inhibitors would be beneficial to these patients as well, depending on which of these pathways were activated. And so there are ongoing trials right now, depending on which of these signaling pathways are activated, patients will receive certain targeted therapies on top of the chemotherapy backbone. And we'll be looking at the outcomes with the addition of those targeted agents. And then I'll just conclude by saying, though, even with these patients with PH-like ALL or Philadelphia chromosome-like ALL, it's certainly possible that they may also benefit from some of these other immunotherapies that I mentioned earlier, blinatumomab, inotuzumab, and even the CAR T therapy as well. And so in certain of the studies that we are running right now, these patients with Philadelphia chromosome-like ALL can also remain on those trials in order to see if the immunotherapy is effective for them in that regard. So really what we are seeing a lot more of is trying to use targeted therapy, immunotherapy to improve outcomes. And then what would be very exciting would be if we could actually replace some chemotherapy with some of these immunotherapies and still achieve the same improvement in how our patients are doing. So with that, I think we'll switch to the Q&A part of the evening.
Yes, thank you very much, Dr. McNear. Very informative. If Dr. Klein wants to come on, and we can start our Q&A. And if any of you on the call would like to submit a question, you can do that through the Q&A box at the very bottom of your Zoom screen. So with that, I'll turn it over to you, Dr. Klein.
Thanks, Jen. Great overview
Welcome.
of ALL. I learned something new every day. So there were a few questions. I think you saw a few of them from folks before your session. So I'm going to kind of go through those.
Okay.
The first question is about immunotherapy and your use of immunotherapy in children with ALL and how successful it's been. And maybe you can break that down by, therapies like inotuzumab, which are sort of, I guess, pseudo immunotherapies, and then maybe CAR T cell therapy and how that's impacted how you treat kids with ALL.
Yeah. I saw that question earlier and I thought it was perfect because that's really what we're looking at right now. And the various immunotherapies are certainly effective in the relapse setting. And that's always where we start with these trials in looking at in patients who have relapsed disease or whose disease is resistant or refractory, are these effective therapies? And they are. And so we want to bring them to the front line. I think the blinatumomab, which we're looking at in our standard risk patients, has good effects and also a more favorable side effect profile. There can be inflammation and something called cytokine release syndrome associated with it. And but it tends to be fairly mild, especially when disease burden is low, which is where we're giving it in these studies. And so that's why we chose that for the standard risk patients. Inotuzumab is, again, very effective in the relapse setting, achieves quite high remission rates using it as a single agent, but it does carry some more toxicities in terms of suppression of the bone marrow and liver toxicity. And that's why we reserve that for our higher risk patients. And then of course, CAR T therapy, which is probably the truest immunotherapy. You're using the patient's own immune system to seek out and get rid of these leukemia cells. It works very well to get patients into remission who have relapsed or who have refractory disease. The question is, how sustained are those remissions, especially when you give it as part of upfront therapy? And that's what we're trying to learn here. So I think what we have are drugs that we know are very effective. We would like to bring them to the upfront setting and cure more children and ultimately be able to get rid of some of the chemotherapies that we use if we can.
Darn mute button. And if you're using immunotherapies as treatment for kids who've relapsed, are any of these considered curative approaches, or are you using them sort of as a link or a bridge, as I often hear said, to stem cell transplantation?
Right. So blinatumomab, inotuzumab, we're certainly not looking at as curative therapies at the moment. Those we're using as a way to achieve remission again in children who've relapsed, and then ultimately those children will go on to bone marrow transplant as their curative therapy. CAR T is potentially curative. There are patients who have gotten CAR T therapy after having several relapses of their leukemia or having undergone bone marrow transplant, but still relapsing. And it can be curative in some children. It's not curative in all. And I think that's what we're trying to also figure out is in which children can that be the definitive therapy and the final therapy, and in which children can it be a very effective way to get them back into remission, eradicate all disease that we can detect, and then take them to bone marrow transplant still as their definitive therapy. And that's still being worked out.
And what about newer bispecifics? Excuse me, blinatumomab is a bit of a pain to administer, if I recall. And of course, in the lymphoma space, there are a large number of new or newer bispecific antibodies that seem to be perhaps a bit more effective than blinatumomab, easier to administer, and seemingly better.
Right.
So are some of those being investigated in ALL and kids as well?
So not yet. So the adult world gets these before we get them in the pediatric world, as you know. The earlier studies happen in adult patients. And then once there is more experience and more safety understanding and things like that, then we are able to start looking at them in children. So we don't have any of those at the moment. You're right, blinatumomab is a pain, to use your words, because it is a continuous infusion. And it's for 28 days. So the children do have to have, they basically have it in a cassette that they carry in a backpack or a fanny pack or something like that while they go about their days. There is a subcutaneous form of blinatumomab, which may have a longer duration. And that's certainly of interest in the pediatric world, because not having to have these children hooked up to this cassette, and of course, their parents and everybody around them and us worried about whether they're going to disconnect themselves by accident. It'd be really nice to have an option that didn't require this continuous infusion.
Sure. And what about other forms of CAR T cell therapy? You mentioned Lymphocytic, which I know is approved for I think people under 25, if I recall, with recurrent ALL. Are there other CAR T cell therapies that have been approved or on the horizon, maybe CD22 directed CAR T cells? Any thoughts you have on those?
So nothing is approved at this point. Lymphocytic is the one that's approved. There are CAR Ts still in development and being studied that target CD22, which, as I said, is the other most promising target in B-ALL. And there are also CAR Ts in development that would target both CD19 and CD22 at the same time, or mixtures of them. Again, just looking at different ways to perhaps target these cells all at the same time to avoid escape mechanisms by the cells.
Right. They seem to be sneaky.
They are, and that's what you can see, which you are well aware, is sometimes after you give these therapies, it puts enough pressure on the leukemia cells where they unfortunately come back, but they no longer express whatever it was that you were targeting the first go around.
Yeah. Okay, great. So kind of an update on immunotherapy. I'm going to move on to the next question. Our daughter was diagnosed with ALL in November of 93. She relapsed in March of 97 and again in August of 2000. Unfortunately, she passed in September of 2000. What treatments have been the most successful since that time? How are treatments given differently? She did have 10 spinal, I think probably craniospinal radiation therapies in November of 1999, which this person presumes is no longer done, which I think is probably the case if I recall. So maybe compared to, a couple of decades ago, what are the major differences? What are the major, improvements? ALL therapy, as you sort of went through, is very, very complicated. It's very complex. So for folks who are not in the business, it's difficult to know, hey, since 2000, what have you done to save more lives?
Yeah. Thank you for the question. I'm so sorry to hear about your daughter. It's always heartbreaking. I think the biggest improvement in outcomes in ALL actually happened back in the 70s or 80s when the delayed intensification phase, or that reinduction reconsolidation, was brought in. And that really led to big improvements, likely because some drug resistant cells that were still floating around were taken out by that phase of therapy. The other things that have really come along since the late 90s and early 2000s are things like giving the way we give the methotrexate in intramaintenance. It used to be where it would be oral methotrexate and oral 6-MP. It would be just what we're doing in maintenance, but we would give that earlier. There was an even earlier trial than the ones I was showing that demonstrated that giving the escalating methotrexate IV was better than giving it by mouth. And then subsequently, as I showed for the high-risk patients, at least giving the high-dose methotrexate instead of the escalating methotrexate was an improvement. So that was a change. We've intensified the consolidation therapy and the delayed intensification therapy a little bit. We've added in some more doses of vincristine and more doses of asparaginase. And there were some intensifications that happened in trials, the generation before the ones I showed, which did improve how we were doing in terms of outcomes. So a lot of that was important, and better identification of the biology, I think, has changed things a lot. So we've learned so much about the different types of chromosomes in these leukemia cells that are abnormal, and using them to what we call risk stratifying the patients and saying, okay, you are not standard risk, you are actually high risk, and therefore you need more intensive therapy. To address the question about the radiation, you're right. We don't radiate many children anymore, which is a good thing because radiation carries a lot of short-term effects and a lot of late effects in terms of neurodevelopment, as well as second malignancies when you do radiation. This is where our intensive intrathecal therapy, all of these spinal taps with all of the chemotherapy, has replaced that for the majority of children. That intense intrathecal chemotherapy still can lead to some neurodevelopmental issues and concerns, but not nearly as bad as they were with radiation, while still really protecting the CNS. So we really reserve cranial radiation now for children who overtly have disease in the central nervous system at the time they're diagnosed, or for the children who still do need bone marrow transplant, we do radiation as part of their conditioning. So I think those are some of the changes that have occurred since the late 90s and early 2000s, the way we give some of these drugs, minor intensifications in parts of therapy. And unfortunately, every time leukemia relapses, it is harder and harder to get back into remission. It always comes back more aggressive than it was the time before.
Yeah. So there's another question about treatment options after the first relapse of childhood pre-B-cell ALL. A question specifically about CAR T-cell therapy as a first level of treatment at first relapse. So I guess question is what are the options for treating first relapse of childhood pre-B-cell ALL?
Yeah. So CAR T therapy, it's not currently approved for first relapse. The approval right now is for second or greater relapse or refractory. So if somebody does have a relapse and you've tried several things to achieve remission again, and you just are unable to, then you can use the CAR T to try and achieve remission at that point. But it's not currently approved right at the initial time of first relapse. What we are doing for first relapse is now there was a study conducted by COG. It just got published within the past couple of years. Using blinatumomab in the relapse setting really made a big difference in terms of outcomes for patients who have relapses that are early, so closer to the time of diagnosis. So that immunotherapy is absolutely being incorporated early on for relapses. But for a lot of relapses, bone marrow transplant is still what is most likely to cure somebody. With time, we'd love to use more CAR T in that setting and avoid transplant if we can, but it's not approved for that indication quite yet.
Great. And one quick final question. There's a question about a childhood ALL survivor who's been battling with depression, and the question is about the association of thyroid disorders and how common they are after treatment for ALL.
Yeah, I saw this one also, and again, I'm sorry to see that your child's going through that, and we have a lot of patients who it's not until they've finished therapy and they're in survivorship that I think they get a chance to really process what they've been through. And so depression and anxiety and all of these things are not at all uncommon in our survivors, and many of our survivors will benefit from therapy, whether it's, with a licensed social worker or therapist, or with a psychiatrist, and perhaps need medications for some period of time as well. That's not uncommon at all. Plus there's the neurodevelopmental piece. As I mentioned before, we give a lot of intrathecal chemotherapy, and that can affect memory and processing and learning and all that. And that can be really frustrating to people, and can also lead to emotional and mental health struggles. As far as thyroid goes, it would be more of a concern in somebody who got radiation. And not necessarily that the thyroid gland itself would be right in the radiation field. The radiation oncologists, really try and tailor those fields where they need them to be. But there's a lot of hormones that are controlled by the pituitary gland and such in the brain. And so if there's an impact on that from radiation, that certainly could lead to problems down the road. But concerns like that, if they're brought up with your treatment team or a survivorship program or a primary care physician, looking at some hormone levels and thinking about these other things are important. And I guess maybe that brings me to another point about survivorship is all of our patients who have been treated for ALL or any type of childhood cancer really do need lifelong surveillance of various types. And there are guidelines that exist to describe what those guidelines should look like in terms of annual visits with either a primary care physician or a cancer survivor specialist, and echocardiograms, and asking questions related to neurodevelopment and hormone imbalances and all of these things, so that way we can screen for late effects that may present themselves. I think you're
Thank
still
you so much. Yeah, we really appreciate your time. I'm going to turn it back over to Carrie to wrap it up. But,
thank you.
We're
Thank
grateful.
you to both of you, Dr. McNear and Dr. Klein. Very helpful. Thank you for giving of your time this evening. A couple final wrap-up comments. As I mentioned, I'll be sending an evaluation out. If you could please fill it out. It just takes a moment. And also, if you found the Q&A portion of this program particularly helpful, we have two programs coming up in February called Leukemia Q&A. We're going to do one with acute leukemias and one with chronic, where it's all question and answer. So we will be sending out information on that. And finally, I will be sending out a recording of this program, as well as Dr. McNear's slides that she's agreed to allow us to share in case you missed something and wanted to go back and see a drug name or see a trial that she talked about. We will be sending that out in the coming days. So thank you again to both of you, and thank you all for joining us, and have a wonderful evening.
Take care.
Thank you so much. Good night, everybody.
Night.